With me is the World Health Organization's chief scientist, Dr. Soumya Swaminathan. Thank you so much for talking to ANI. We really appreciate it, ma'am. Now, the Institute of Health Metrics and Evaluation has estimated that by August 1st, India will see 1 million deaths. Now, if you go by the nature of the virus and studying the patterns, what impact can the variant have on people's lives in India over the next 4 months? And what is your take on the official data that is being released and rolled out by the government of India?
Thank you, Reena. You asked several questions, so let me try to take them. The Institute of Health Metrics and Evaluation, does projections based on models, based on available data, and some parameters that they feed into the model to project what the future could look like. Let me say that a model is not a prediction of the future; it's a scenario, and the scenario depends on many, many things. And those are the things that we need to look at and change. So to me, when someone says this is going to happen, I feel it's up to us to change that. And we don't have to let it come true. So I would say that at this point of time, the situation is very worrying. The daily number of cases and deaths that we're seeing today in India and in other countries in the Southeast Asia region is of great concern to us. And we also recognize that these are underestimates that every country in the world, in fact, the number of cases and number of deaths has been an underestimate of the true number. And we need to do some exercises, to try to find out what the missed numbers there could be. But that's a separate exercise. It should be done, and we should be aware because the better the data, the better the policies can be directed towards what's happening. Because let's remember that when we talk about excess mortality and people dying, they're not dying only of COVID. People are also dying of all the other illnesses for which they may not be able to access healthcare. So all of that together constitutes excess mortality, and studies should be done, and we have a methodology now that we share with countries who want to do that. Having said that, I think today the focus needs really to be on getting the control of the transmission, bringing cases down and bringing deaths down. And we've seen in country after country that the moment you start bringing cases down, you will also bring deaths down. It always follows. There is a lag period between the peak in cases and the peak in deaths. There's a lag of approximately 2 to 3 weeks. But it goes without saying, once cases come down, deaths will come down. That should be our goal just now.
Right. Now, even though that corporate America might protest, but the potential of a patent waiver on COVID-19 vaccines is worth fighting for. And this is something that we've heard from WHO time and again. Do you think it's time for countries and corporates to step up and pass that temporary waiver on intellectual property rights? And this should be done immediately because there's a whole bunch of legalities that are involved in this, which are time consuming.
Absolutely. So the WHO strongly believes that the TRIPS waiver that was proposed at the WTO by India and South Africa should be done. And the DG, Dr. Tedros, has often spoken about this and the fact that this is the time during a pandemic to not worry about patents and profits, but to really think about how do we increase the access to the tools that people need, whether it's diagnostics or vaccines or drugs. So yes, we would like to see that happen very quickly at the WTO, but that needs to be also accompanied by a technology transfer and know-how transfer because vaccines are complex things to manufacture, and it will take a long time for a company to learn to do it from scratch, even if the patent is not uh, implemented. So what we need are the people, the companies who have the technology and the know-how, let's say for the mRNA vaccines, to be willing to share that, to be willing to transfer the protocols so that companies in other parts of the world can also start manufacturing and scaling, because at this point, what we need to see are supplies of vaccines increasing globally.
Right. Do you see any timeline for this anytime soon for it to all settle down and maybe, the waiver being given to countries? Do you have a
I
timeline?
cannot, I can't predict that because there's obviously negotiation, and I don't think there's a unanimous agreement on that as yet. So I think there are still negotiations to happen. But what I can say is that we don't need to wait for that. We can still do the technology transfer in a voluntary way without waiting for the patent waiver, because if a company decides that they will share their know-how and their expertise and their protocols for making a vaccine, there is nothing whatsoever to stop them from entering into a licensing deal, and that's what we are trying to promote. We're saying that there are many ways of doing this. One is to go through voluntary licensing, which some companies have already done. We want to see more of that, and we want to see it being done under transparent terms and conditions, so that the supplies of those vaccines from those licensing deals comes to COVAX and can be equitably distributed around the world.
Right. Now, vaccine equity is another challenge that countries like India and Brazil are facing at this point. Studies show that 82% of the vaccines have been provided to upper middle income countries. Do you reckon that the rich developed nations have failed India or countries like Brazil? What's the right global strategy at this point?
The right global strategy should be one of solidarity and collaboration, because it's a pandemic we are fighting. We cannot fight a pandemic a country at a time. We've seen country after country face this situation, right, including the high income countries. So it's not like the high income countries did not have a problem. They did. And they need to vaccinate their populations also, just like everyone else does. The issue has been that the doses were pre booked by high income countries, so that there wasn't enough supplies to come into COVAX. And countries like India are actually manufacturing hubs. So they're not exactly in the same situation as countries, say in Africa, for example, where there is very little manufacturing happening on the African continent. So they're completely dependent on imports of vaccines. But at the same time, the vaccines that got ahead in the in the process of development were those that were developed by the large companies and that had advanced commitments made to the high income countries. And that's where we start seeing this imbalance. It should start getting better in the second half of the year as vaccine supplies, ramp up. But in the next couple of months, clearly supply is less than demand. And so we need to use the supplies we have wisely and prioritize vaccination of the high priority groups. WHO has defined the populations that should be prioritized, like the frontline and healthcare workers and the older people and those who have underlying conditions. So because we want to stop deaths from happening before we vaccinate the entire adult population of any country.
Right. Genomic surveillance programs have let scientists like you track the coronavirus over the course of the pandemic. I mean, starting from 2020. Do you think India was caught unaware by the second wave of the COVID-19 infections in large part due to its inadequate genome sequencing?
So genomic sequencing actually adds another layer of information on top of basic epidemiological surveillance, which is a surveillance of the positivity rates among admitted patients with influenza-like illness or with acute respiratory infections. So that's the surveillance that should be alerting public health officials if the cases start rising gradually. And what genomic surveillance does is to add more information about the type of virus that is circulating. And as you said, right from the beginning of this pandemic, we've had many countries, including India, sharing the genome sequences with a public database called GISAID, so that scientists across the world could see how this virus was changing and evolving. So while I think that for a large country like India, yes, we need to do more genomic sequencing, we need more labs, we need to do it in a more representative manner so that we can understand what's going on in different parts of the country over a period of time. You can see some strains going down, other strains rising, and that needs to be done hand in hand with clinical and epidemiological studies. Sequencing alone doesn't give you the full picture. So you just by looking at a sequence, you don't know whether it's more transmissible, whether it causes more severe disease, what impact is it having on diagnostics or vaccines. All of those studies need to be conducted side by side. So it's quite a big research exercise which is needed. But India is one of the few countries that has the capacity to do that, and I think now it's really picking up the rate at which the sequencing and the other investigations are happening.
Now, regarding resuming travel, we know that a lot of travel has been restricted by many countries. What threshold would you like to see established in order to determine whether it's safe to resume travel to India? And what are your views on the vaccine passport? Do you think that's the way forward?
So the issues around travel, are addressed by the international health regulations, which themselves are being now reviewed by the IHR review committee. So we have the committee called the Emergency Committee that meets every 3 months whenever there's a public health emergency declared. And they actually look at all the recommendations and update them. And basically, they have been um, so far saying that the vaccine passport should not be a precondition for travel. And I'll explain why. There are scientific and ethical reasons for that. The scientific reason is that just because you're vaccinated doesn't mean you can't get the infection. You are protected to a large extent, but not 100%. So you could still get the infection. You could be asymptomatic and be perfectly well, but when you're traveling, you could infect others. So that's the scientific reason for saying that a vaccination card doesn't mean that you're totally immune to infection. The ethical argument is, of course, that not everyone has access to the vaccine just now. So you're already creating a double disadvantage group. An advantage group who's been fully vaccinated can freely travel, and the disadvantaged group who wants the vaccine, it's not that they are resistant to it, they want it, but they haven't had an opportunity to have the vaccine, and they are being prevented from traveling. So I think we need to make the travel rules, which are both based on science, but also on equity and ethics. And you can do safe travel. I mean, in these months, airlines have been flying people around the world fairly safely, I should say. We haven't had too many big outbreaks on planes. So it can be done. The risk needs to be assessed. Countries, of course, assess the risks, of travel from other countries depending on their own situation and depending on. So that, is a country by country decision. But the WHO has clearly got guidance on how and when, where to control travel and how to do it safely and manage the risk appropriately while keeping in mind the human rights and ethics principles also. So we're not discriminating against people just because they don't have a vaccine or they don't have a test because they may not have access to it or they may not be able to afford it. So those are the complex issues that come in. But just to finish on that vaccine passport, what we're saying is that we need a digital vaccination certificate, and that should be separated from a vaccine passport. So a certificate, digital, is very good for someone to have because you're moving away from paper. It's a permanent record. You can take it and carry it with you. It can be interoperable in different countries and so on. So that's and we've developed the technical standards around how countries could make such a digital vaccination certificate. But how you use it and whether you use it as a passport or not, that's where we have clear views on it.
All right. Now, there was a recent article that was published quoting you that the double mutant strain in India potentially is resistant to the vaccine protection. Sometime back, you even tweeted, I just went to your Twitter timeline just before the interview, and you said that you've been misquoted. How do you brush up upon this whole confusion about the double mutant strain and its relationship to responding to vaccines?
Sure, and thank you for asking me that. So let's call it by what it is, a B1617, because the double mutant is scary and we don't want it to be known as an Indian variant either. So we've given numbers. I know it's very hard to remember, but the B1617 is a variant that was initially identified mostly from Western India, Maharashtra. Now it's spreading. I mean, it's becoming quite common in India, though we also have the B117 strain, which is the UK, which is identified in the UK, which is also quite common in India. So there are several strains that are circulating, and over a period of time, we track them and see which goes up and which outcompetes the others. So what we know about this so far is that it does appear to be more transmissible, at least as highly transmissible as the B117, which we know from the experience in the UK really took off last year in October, November, and spread very, very quickly. So it's highly transmissible, maybe up to 1.5 to 2 times more than the normal virus. And so, on that basis, the WHO committee today met, looked at all of the data, and has classified it as a variant of concern. We had 3 variants of concern so far. This becomes the 4th one to be added now globally. we are still not having any data on the impact of this strain on either on diagnostics, so it's still responding to all the RT-PCR tests, on therapeutics, so same treatment protocols will work, and on vaccines. There is some small bits of data from the ICMR and the Bharat Biotech vaccine showing that the neutralizing antibody that's needed to overcome this virus may be a little bit higher than we need with the normal variant, but it's definitely not of concern. We know that the INSACOG and the Indian government institutions are working on these studies, and we expect that in the next 2 to 3 weeks we have much more data on this, as I said, on the clinical profile, on the epidemiological profile, and the lab experiments which are being done now to look at the antibody response. So for now, the message is it may be more transmissible, but it behaves in the same way as other viral strains. You have to take the same precautions, so nothing changes. Vaccines are still very effective against every variant in the world in protecting against severe disease and hospitalization. So, some people quote cases that X and Y got infected after 2 doses of the vaccine. So why bother to take the vaccine? No. The data from the US has just come out. It's very dramatic. 95 million people in the US have had 2 doses of vaccine, and only about 900 of them actually got hospitalized for serious COVID-19. So you can imagine, out of 95 million, if people had been unvaccinated, the numbers would have been at least 100 times more. So extremely effective against causing severe disease, but not fully effective against preventing infection. So I think the message is take the vaccine as soon as it's available. Whichever vaccine is available, as soon as you're eligible, get it. That's going to protect you from getting into that ICU.
Now, lastly, as a person of Indian origin, what response would you really like to see in India? Something that has science at its heart, that is not allowing science being politicized? Or do you think that India needs to be more transparent, needs to have a more transparent public policy-driven response?
Yes, well, Leena, this is something that we've talked about, right from the onset of the pandemic. The fact that the policies need to be based on data and evidence. And of course, in the beginning, we knew very little. And then as time went on, we learned more and more. We still continue to learn. So we have to continue to adapt our policies. We cannot become static. So I think that for any country, what's needed is, first of all, strong leadership, which is based on science and data and public health principles. That evidence needs to be updated from time to time. Even if you take treatment or you take, the public health measures, anything. When the evidence changes, the guideline has to change. And then that needs to be communicated, of course, to people. So data transparency, communication, explaining to people why certain decisions are being done, why certain other things are not being done, explaining to people the rationale and the science behind the decision making. I think goes a long way, both in improving trust of the populations, but also in helping them to comply with sometimes which are very strict and difficult restrictions that one has to impose on people. So if they can see the data, the parameters on which these decisions are being made, and the fact also that, of course, when you're dealing with a country where there are large numbers of poor, then you also need to step up the social protection mechanisms, because as I said, all of these stringent public health measures come with consequences on livelihoods. So that also needs to be taken into account. So I think strong leadership based on science and evidence, data-driven, and for a country like India, again, the data has to be granular. It has to be down to the district and the village level. And then communication, which has to be both with transparency, but also compassion and humility.
बहिणाबाईंची जात्यावरची ओवी म्हणजे